tonight to say that anybody is right or wrong. We are just giving you an example of how it can be done, and hopefully our intention is to give you the confidence to be able to ask your own questions and have a constructive consultation process. So Chinta, welcome to our group, and thank you very much for joining us again. We really enjoy having your sessions here. Can you tell us about informed consent?
Thank you, Jackie, for inviting me. It's a great pleasure. I've enjoyed the last session, and it's nice to be here again with you guys. So I'm tilting the idea slightly towards how patients can prepare in order to give informed consent. So that if a patient can arm himself or herself with the information needed, which forms the basis of this transaction of consent. So for the viewers, I'm Srinivas Chintapatla. I'm a consultant surgeon at York and set up the York Abdominal Wall Unit. I teach at the Hull York Medical School, and half of my job is being a director of cancer and support services. I show York Minster, very proud of it, very beautiful, and a sucker for a really lovely sight for eyes and heart.
Beautiful.
So, thank you. So the center of this whole informed process, in my view, is the patient and what the patient's needs, understanding, and desires to ask the questions are. So I've started my slide because that is the center of this whole informed consent. It's the patient having all the information so that he or she can give consent to the surgeon doing something to them in order to make them better. So that's the transaction between the patient and the surgeon. And it's underpinned by information. Now, I've shown a traditional book. It could be a book, a leaflet, but these days, we are getting all our information off the net. And the important bit over here to stress is that it has to be something that you believe in, something that is reliable, something that a learned society is backing, something that your surgeon can clarify. So it is important to know the source of the information and the reliability of the information. But that information is something that you as a patient would quiz, understand, see it from your own angle, and have a dialogue with the surgeon. And that, I think, is the essence. I think your starting point has to be, what do you as the patient want? What do you want? Do you want the hernia to disappear, or are you looking for your pain to disappear? Or maybe what you're looking for is something else. So that clarity is really important. What do you as the patient want out of this discussion? And central to that is your story, what happened before, what other issues you have. Maybe you have diabetes, maybe you're a smoker, maybe you're not. So it's important to look at it not as an information leaflet somewhere, but personalize it to your story. And to do that, the center bit is asking some questions, spending some time on this idea. How does it affect you? And by that, you will see the words use quality of life, but essentially it is, how does it affect your life? Does it bother you in this way or in some other way? And is the aim to sort that quirky problem that you have in life? Now, we find that when we send the patients a document which has this shared decision-making paragraph, wherein the patient sits at home, has a cup of tea, and writes down what matters, that clarity of thought, that ability to say what you want out of the consultation and what questions particularly are bothering you. I think if you take some time, sit down, because in a busy clinic, you may not have the the words that bring out the exact nuance. And so I think spending some time preparing for that consultation is well worth it. Uh, we did some work on asking patients how it affected, and what we came out with was that it might affect, causing you some symptoms, some discomfort, some difficulty in breathing or pain, and how you alter and adjust in life to that. It might be affecting your mental health or your body image, or maybe social relationships. Maybe you're embarrassed, you don't go out, maybe you reduced your meetings with friends, maybe sexual relationships are an issue, or maybe it has an effect on you, on your employment even. We wrote down all these, and this comes from a peer-reviewed paper. So it's something that you can rely on in terms of patients telling us how it affects them. There's a lot more detail to this. So we the idea of a busy clinic was a bit too difficult to get all the information. So we created this questionnaire, which is available on the trust websites, wherein a patient would go through all the story and write down details. Where did you have your surgery? Who did the surgery? Do you have any infection afterwards? Or your exercise tolerance? Can you walk a mile? Or maybe you can walk only a few hundred yards? Or all those other issues which are relevant. What I called earlier your story. And in that, we've given sections for people to talk about in terms of their body image. This gentleman talks about feeling like a freak, or this condition, or trying to explain that this condition is not my fault. This is something people are really bothered with. They think they've done something wrong, and perhaps that's what's happened. But putting words to paper, I think, helps, or so my patients tell me. So body image or about mental health, how it is bothering you. Maybe depression is setting in, maybe not. Maybe you're looking forward to a life where the hernia has been repaired. And so things like employment, social relationships, and these are examples of what one particular individual has written, and I'm sharing them with you with his permission. So then comes how that single person has said what matters to him, what he hopes will come out of the consultation, what questions he would like to ask, and so on. So that interaction in your consultation process, where the story is reviewed, your effect on your life by your hernia is discussed, and focus is put on what's important to you. And then it leads to a proposed management plan. It's for discussion, it's for slightly changing, altering according to what's needed, and then the information that follows it, and see if the expectations that the patient had before, what they wanted from the consultation, has been met. So, so therein lies the three important parts of informed consent: information, and that transfer between the patient and the surgeon about what the patient wants and what the surgeon anticipates would be the course of events. So we talk about this information, and we went through to create this leaflet. It took us about 2 years to do that, and there are various components on it, and you can access that from our trust website. But we outline the benefits, but also the risks from the surgery, what those risks are, and a lot more detail than I have shown you over here, because I've just taken the first line and edited it to put it over here. But there's sections on it so that one talks about incidents and what happens if that risk does materialize. And in the clinic, we then dictate a letter after discussing the leaflet, and then we personalize the letter so that it's a procedure specific paragraph in a letter, so that it mimics what is written in the leaflet, so that you are now a person is getting comfortable and listening to the same discussions in a different nuance, and it's becoming specific for them. So the work that came from patients. It started off with patients and then senior consultants who had an interest in abdominal wall, writing a leaflet and then putting it through plain English and information governance and doing this 3 times. We've published on it. So there is a peer-reviewed process behind this. So the first bit is the information that comes through, and the patient takes the leaflet home, and hopefully they act as for those discussions. And at home, once the letter has been typed up, there can be some delay, but then when the letter reaches you and you read the letter, that's your second prompt that happens for thinking about things. And in parallel, because the letter and the leaflet are visible to the pre-assessment teams and the prehab teams, they know what the patient's perspective and what information has been given. And um, and let's say there is not much to optimize, and we putting the patient through for surgery. But 4 weeks before the surgery, we are planning on a Botox. So when the patient comes for the Botox, we introduce the consent form. Now, this was something that Sue, who is another patient representative like Jackie at the British Hernia Society, in her discussions talked about a consent form feeling like a legal burden, like that is something to protect the surgeon, and to take that kind of fear away. We have started, the idea came from Sue that we introduced the consent form beforehand, and I took the opportunity to introduce this 4 weeks before so that the language is familiar. And I go through that. Um, that's our trust consent form that we use. It mimics exactly the same risks, and talks about the intended benefits, talks about alternatives, and talks about the leaflets that we have provided. And then you see there, I'm introducing the consent form to the gentleman when he's come for his Botox being done, and I've signed it, and I'm giving it to him to take home. Along with this, we talk about the final 4 weeks. It's like your last bit of preparation you're doing. I talk about the strength exercises, the core stability, the final push for incentive spirometer to do breathing exercises, abdominal wall exercises, and leg exercises. So we talk about that. And then on the day of surgery, the patient signs the final consent, the informed consent, in order to proceed with surgery. So in summary, there are 3 aspects. There is a information leaflet that's been designed. There's a patient procedures paragraph which personalizes that leaflet to the patient. And then there is a consent form, which is a pressy version of all those risks and benefits and alternatives available. And I think that becoming together allows that information to be shared so that you can create a decision which works for you. And I think what I'm trying to show is how you can prepare and get that information needed in order to have a proper and successful informed consent. I put up the link for the trust because some of the leaflets I've talked about and the consent forms are available over there to see.
Thank you, Chinta. We will share that link in the group shortly.
Okay. Shall I stop sharing then so that we can then, or do you want me to leave this on?
That's fine, whatever you, either way.
Okay, all right.
So I do like the idea, what you said there about writing everything down, because when we get in front of the surgeon, everything just goes out of your mind, doesn't it?
Yes.
And I think if we do write down,
it's not specific for surgery. I went to the GP with 4 ideas of things that I wanted to say, and I walked out having said only 2. So it's something about the process and the room.
It is. It can be very overwhelming. So to be able to do that and write everything down at home, what you want to discuss, and then take it in. And it is important to consider how your hernia is affecting you. Like, we have a man, and he knows who I'm talking about. He hasn't been able to work for such a long time.
Yes.
And he's desperate to get back to work, to support his family. And that's, hernia affects everybody so different. And I think that's one of his main ambitions from the hernia surgery, is to be able to go back to work.
And what a fantastic ambition, isn't it?
Yes.
The gentleman is going to return to society as a person who is going to work on, and his sense of self from contributing to society and
Well,
feeling burden of not being able to do so. These are really strong feelings, and I
it
think,
is.
yeah,
It is, and
very
it's
good.
something that the rest of us take for granted. And it's
Yeah,
only when you lose that that it becomes important to you. And I
yeah.
really do hope that it happens for him very soon. But also how the hernia affects us. And I think sometimes we're almost embarrassed to talk about mental health, how a hernia affects us emotionally, mentally, emotionally.
Yeah, yeah.
It's embarrassing walking around with lumps and bumps, and it's fine to feel like that because it isn't our fault that the hernias are there. And I think that's a big thing that we need to get through to patients, that it's nobody's fault that this has happened.
Yes, you know, things happen. You cross the road, something goes wrong. This is life, and sometimes complications happen and hernias happen. I think there is more of evidence coming out about the rate of hernias after laparotomies, and more research happening about why, and surgeons and patients and the industry is trying to figure out ways in which you reduce that incidence of hernia. A lot more work is needed, work on sutures, type of sutures, the thickness of the suture, the kind of stitching, uh, the importance to stopping smoking, the importance of becoming stronger before surgery. All of this makes a difference. And I think we are getting better, but there's lots more to do.
I agree with that. It is getting better, and units like yours are fantastic, but we have to filter that down now to some smaller units who that can then help their patients and maybe not necessarily receive the same, because not every unit is different,
Yeah.
but to know, for patients to know where to go to access this help, and maybe physio and prehab. I think we're hoping our next session is going to be about weight loss, because that's something we all find difficult.
Yes.
And that can be difficult to talk to your surgeon about. I
Yes.
found it embarrassing
Yes. I
to
think
talk.
one of the key things in writing that, those questionnaires was that it's not only time, isn't it? There is also something in your own mind that your ideas don't come to you and you feel embarrassed to talk about it. But when you are with yourself alone in your home,
Yeah,
without an individual in front of you, you might be able to, and this is a generalization, be more frank with a piece of paper without someone in front of you.
yeah, you're more relaxed, aren't you? And you can be
Yes.
honest
Yeah.
with yourself. And at the end of the day, if it is written down on a piece of paper, if you don't feel able to approach the surgeon and say it verbally, you can always pass that piece of paper to the surgeon
Yes.
and
Yeah.
say, this is how it is affecting me. I can't talk about it, but
Yes. Yes. Yeah.
that is
Yeah.
my feelings.
And some of these are, the more I'm doing research on patients' perspectives, the more the strength of feeling is becoming obvious to me. The mental health you talked about before, and the body image and feelings of guilt and so on. There is so much that is there which a patient might find therapeutic to put down on paper and face these, because that's the get things better, and start working on what is needed in order to have a successful outcome.
Yeah. So we do have questions that, what sort of questions do you talk about with your patients about their operation? In the consultation, you discuss how long they're likely to be in hospital, the recovery rate?
Yes.
Um,
Yes.
I think all that
So, sorry.
patients need to know. We need to be prepared before we go to the operation, what we're going to face when we get there. So
Yeah.
I think it's important that we have an idea how long we are going to be in hospital, to discuss this beforehand. And what is our recovery going to be like? I think that is also something that is a big thing. And I also think that before the consent, before the operation, during this process, we need to discuss pain management as well.
Yes.
Because that's something that frightens patients, how much pain we're going to be in.
Yes.
And also that the pain it can still be there. It's normal to feel pain for a few weeks, even a couple of months after surgery. It's not automatically just going to vanish as soon as
Yes.
you've had your operation.
Yes.
You know, you are actually going to cut us.
Yes. Yes.
Basically.
And honesty and management of the expectation and a bit of truth in what is the post-operative course goes a long way, because if you tell them this is what is going to happen and that happens, then it doesn't feel as if something wrong has happened.
No.
So your expectation.
That's it. That's the whole point.
Set,
if
isn't
we're prepared.
Yes. So yes, the leaflet I mentioned, we talk about their grades of recovery. We have another leaflet which talks about the exercises you do at home before the surgery, what you do in the hospital, and what you do after you return. So we graded it like that, and we've tried to provide practical advice about walking around, doing the things you want, driving cars or going back to work. And each one of that is specific to an individual, and there's a little bit of pragmatic setting of goals, and I think it's worth talking about, as you said, Jackie, because in a way it allows the patient to know what is expected, and also they set their own goals and try to beat and reach a goal, and that provides positive reinforcement that all is happening well.
Yeah, I agree with that. I think it's important to be armed with all this information. And I also think, I don't know what I was expecting personally when I had my first operation, but I wasn't really prepared for the scar as well.
Yes. And yeah.
I know some people get upset that they've lost their belly button.
Yes.
And we need to be prepared that can happen. What is our abdomen going to look like after the surgery?
So one of the aspects we tackle in that leaflet is about the appearance of the abdomen and the scar, and sometimes so that you talk about the lopsided nature of the two halves on either side of the scar. We also actually talk to them beforehand about what their feelings are about belly button. I have had one gentleman who was absolutely certain that the belly button had to be there, absolutely certain. This was important for him, and so we had to design the operation preserving the belly button, because that became an important thing in what he wants out of the surgery, and you have to design the answer to what the person is seeking, keeping what the person wants in mind.
If it was important to him, then
yeah, absolutely.
Yeah, I look like I've got about 3 or 4 belly buttons now, but
sure you don't. Sure you don't.
But yeah, I think it's important to talk about things like that. And the other
thing, sorry. Well, I was about to say that because we have a plastic surgeon in our clinic, so we do the clinic, myself and Mr. McLeod, Phil Lim, who are the two plastic surgeons with a big interest in abdominal wall reconstruction. And so the discussions on appearance and the discussions on umbilicus are headed by them.
Yeah. Sorry. The other thing what I think is important to discuss is getting back to normal, to normal activities as well. When can patients start to go back to work, start driving again? And that, I think, is when you can safely say you're not under the influence of any medication. But also talk to them about when can patients have sex again? Because that's something that comes up quite frequently, and people are often embarrassed to ask that question.
Yes,
I think we need to be honest about what we want after surgery and what is important to us.
So in terms of recovery and driving, I say to patients to test their ability to do an emergency stop at home in a stationary car, because that is the rate limiting. If you're thinking about your abdomen while you're driving, you probably won't be able to react and do the emergency stop. And that, I think, is a very rate limiting factor. The other thing is, I think it helps patients when they have an abdominal wall binder after surgery, because that provides them first the support, but more the reassurance they're looking for, that they have done something additional to what the surgeon has done, that they have done something else to protect themselves. I think a lot of patients say, I like having my abdominal wall binder. It helps me feel more comfortable and feel more confident.
But
So,
how long do patients wear them for? That's the other thing that.
so that's variable. My experience has been that once the patients are comfortable and have forgotten about the surgery, they stop wearing it. I do suggest that they use it for a long period of time till they have reached that point of being completely comfortable.
Yes, yeah,
Almost at least 3 months.
right.
Most of them like to keep on and seem to benefit. It seems to give them assurance that they
Yeah,
are doing something, rather than you talked about at one point about pain management. The role of abdominal wall binders is not in reducing seromas or so on, but in the immediate post-op period, in lessening the amount of pain, and so changing the medications that you're needing. And that's the limited evidence that's available. There's another bit about patients' perspective and about how they feel more comfortable and confident, which is a different issue.
yeah. Binders is something that people do rely on, and that also causes a lot of confusion, because I don't think surgeons know how long to tell people to wear them for. So they just leave patients to their own devices, and then patients tend to panic. Am I allowed to take it off? Can I take it off? And especially in this weather, when it's hot and sweaty, it's nice to take it off for a little bit to get some fresh air to your abdomen.
Absolutely.
If you're not doing anything.
One of the tricks patients tell me works is if they're wearing a t-shirt and then the binder on top of that.
Yes.
And the other thing that seems to make it acceptable is when they take off the binders at night. So don't use it all the time, get a good night's sleep. Sleep is so important in your recovery.
Sleep is the best thing for you to recover, isn't it? Yeah. Okay.
You talked about pain earlier on when you were mentioning questions and this thing. So we have a pre-assessment session where the pain management is discussed, whether it is epidural for pain or whether it is pain busters, which is 2 catheters being placed in the abdominal wall through which a local anesthetic is pumped for a period of 48 hours. So there are many, many different ways of managing pain, and that surgeon's unit will have a certain way of managing pain, and asking, and is part of those informed consent, what that unit provides in terms of pain relief.
I think that's important, because it is a big fear for patients when they go in hospital, is how are you going to control my pain?
Yes, absolutely. Very important.
Like you say, every unit will have their own ways of doing it, but it's something that I think we need to ask more and more of before we go there, then we're prepared for it. As the binders, they help. Ice can help, can't it?
Yeah.
Something simple as a bag of frozen peas sometimes.
Yes.
Help.
Altering the pain gate pathways of pain.
Yes. The other thing, I think is good to talk about is the prehab, and what can we do to make it better on the day, and talk to your surgeon about self-help on that. What can we do before? And do we need to take any supplements for the fiber? That's another thing that people often get concerned about, because the pain relief has the nasty side effect of us being constipated.
Yes.
Is it better to prepare for that beforehand by building up with the fiber beforehand? And that's something that everybody can talk to the surgeon about, and maybe write that down in your leaflet.
Yes, and we have the benefit of a pre-assessment session where the nurses are trained in I talked in what the surgeon is talking to the patient, because our leaflet is visible to the nurse. He or she knows what it is that I have been saying to the patient. So there is a lot of benefit in the same message that goes at different times by different professionals, and having clarity on what that message is going to be. So the same booklet that we talked about is being used by the pre-assessment nurse to refer to what has been said. The letter is obvious, and the patient's health questionnaire is scanned and put onto the computer database so that they know what it is that the patient's worries are, which have been written down beforehand. So I think this kind of circular revisiting and putting the patient, as I said in the first slide, as the center of all of these discussions, but creating a process that allows the patient to hear the message a few times.
Yes.
Because it's not possible, I think, for anyone to retain
No.
all of what you said,
Not at
let
all.
alone 50%. Some say that after a clinic, only 20% is remembered.
Well, I think that's right, because we're going to sit in front of you. You're going to tell me, "Oh, I'm going to cut you open," and then you expect me to remember everything you say, which is
You
why
probably
I think.
stop thinking after I'm going to cut you open.
But I think we have to have somewhere as well that patients can find quality information, not just on abdominal wall hernias, but also on like inguinal hernia and umbilical hernia.
Yeah.
And I think that's my challenge now that I will throw down to British Hernia and the European Hernia Society. Let's get this done for patients, and let's lead by example that this is what patients need, somewhere to go. And if we can set this example, then hopefully the smaller units will follow, and they can direct patients to where they can find that good information.
I've seen a really good leaflet European Hernia Society created on umbilical hernias, patient information leaflet that was really beautifully written, and I think they must have thought a lot of the plainness of the language, because it was a really nice one, I thought.
Yes, I think we can make those more available to patients.
Yes.
And, hopefully when the new registers come out, then that's going to be important as well. But yeah, I think patient information and giving them time to go away, find out, think about what's important themselves, come back and then sign your consent form beforehand. But what happens when it's an emergency operation?
I think what the risks of the patient when nothing is done is very high. So the benefits versus risks ratio changes, I think, in an emergency situation, because your option of doing nothing or doing something alternative, like just using an abdominal wall binder, becomes not feasible. And so the focus still, these principles are still the same. You're talking about the benefits and the risks of the surgery are higher, but so are the benefits, because you might have come in with obstruction or a threat to life. And so that balance between the benefits and risks, the operation may be similar, but your focus is about stopping the obstruction or removing the bowel which is not working or doesn't have blood supply and so is not healthy. So the focus is changed. I don't think the principles change, but the focus of what is the benefits changes. What will be the benefit or risks of not doing anything becomes really important.
Yeah. So in that situation, do you then assume consent?
No. The
If the
patient
patient is able to give it.
If the patient has capacity to consent, by which I mean the mental capacity to consent as defined in English law, no matter how big the emergency is, you can't assume consent.
Right.
There has to be a discussion and the patient has to give consent. The principles are the same. The time is shorter. The discussions perhaps are not at length, but your discussion about the risk and the benefit must remain. And it is the patient who provides informed consent.
Right.
Unless the patient is unable to do so at all, is completely unconscious, and in that case, best interest goes ahead, and assent is assumed. But no, even in an emergency situation, the patient holds all the cards.
That's good to know. I'm sure that's quite reassuring for people. The other thing I think that patients worry about is coming home with a drain.
Sorry, say that again, please.
Is having a drain in place. How long
Yes.
are they going to have a drain, and how long will that last? And do I have to fetch it home with me?
Yes.
What
Yes.
do I do?
This is a common discussion about the drains, because sometimes when you first mention a drain, a patient would say, "Oh my God, will I have to stay in hospital till the drain comes out?" And that's not necessarily the case. Some surgeons don't use that many drains. Some surgeons use more drains. It depends upon the operation and what happens to that individual at that point. And there are strategies these days of reducing seromas by using various powders, but there are strategies of leaving drains until nothing comes out. So it depends on what that surgeon and you discuss and decide upon. But talking about it, and I sometimes send patients home with a drain, but we have a sheet of paper which has marked on it how to mark the output. We send them home with a syringe. We teach them how to empty the drains only if necessary, so it doesn't become a barrier to early discharge. But that depends upon the patient's feeling comfortable, and that there is a little bit of education and teaching to happen. But more often than not, they go home without any drains.
That's good. That's good. I remember carrying mine, had mine on when I went in hospital, and there was a little old lady in the bed next to me. Used to think it was a handbag, and she used to keep trying to get hold of my drain, and I'm like, no.
Yeah.
The other thing I was thinking as well we need to talk about is wound care.
Yes.
How long stitches are going to be in place, or staples? Are you going to have stitches? Are you going to have staples? How long are we going to leave them in place for? What do I do with them? Is there anything I need to do to look after my wound? Can I shower with the stitches and the staples? And those are other things that patients need to be aware beforehand.
Yes, and this is something which is different, isn't it, in each unit?
Yes.
Because some units will use a subcuticular stitch which will dissolve. Some units will use a stitch that needs removing. Some will put staples which need removing, and that is very variable. But it is again part of the information that goes into allowing a patient feel in control of what is happening in a hospital. Hospitals are places you go in with a sense of losing control over what everything feels alien. There are tubes, there are bags which are transparent, which have fluid going into you. All of this is a bit alien. You understand it's needed, but you're never quite sure what's happening around you.
No, it's like an out of body experience in a way, isn't it? It's like it's happening to somebody. You're just going along with the flow.
Yes.
Yeah, so I think.
But this is an important thing to talk about, because when they're alone at home, the dressings are what worry them. A little bit of seepage that they think something's gone wrong, or that reassurance that's needed, a practice nurse seeing the wound once they have discharged from the hospital. All of these are important things to talk about and assure the patient more than anything that of what to expect, so that if the thing that is unexpected is happening, then they can raise alarm and get in touch.
Exactly, they know who then to talk to, contact, and when to contact somebody if you're aware of what is happening. Yeah, because a little bit of fluid is fine.
Yes, exactly. Yeah.
it's better to know these things. So, as you say,
Yes, that if the wound is getting red or it is hurting, it's locally tender, swollen, then that indicates something more than a little bit of fine fluid. And so then you need to start thinking about how to seek help, and the discharge letter should know who is the person you contact and what are the contact numbers and things like that.
Yes, and who to contact is, like you say, we don't always see the discharge letters. I don't think you always get them at the time. Not everybody gets them.
All right. Okay. Yeah.
Some units, they don't give them out. I never got a discharge letter.
Okay.
And I think that's important. If the unit isn't going to give these discharge letters or everything, to know when to call them and to have these discussions with your surgeon before we go to the hospital.
Yeah. Every unit has its own way of working. And I remember the times in York when we had a handwritten discharge letter, which would be very variable because, you know, my handwriting is rubbish.
I think that's one of the prerequisites of being a doctor, isn't it?
So it's variable, shall we say?
Yes.
And so you don't quite know which bit of it is the number that you have to contact or how to access care backend. This is an important part of feeling safe for the patient.
Yeah. Like you say, every unit has their own way of working, and the aim of tonight isn't to criticize any unit.
No, not at all.
The aim is to give patients the information that they need, that they can then feel empowered to be able to go and approach their surgeons and get the most from their consultations.
Yes. And you know, what I've shown is an evolving subject. This is not how it was 4 years ago.
Not at all.
A year ago, we didn't have the introducing the consent form. That's something new. So that it's a journey. Both of us and others are going through this, and in time, 10 years from now, perhaps the leaflets you're championing would be available throughout British Hernia Society and European Hernia Society and so on.
Yes, hopefully. So I've seen a massive difference in the last few years over how hernia surgery is approached. So onwards and upwards with that.
Yeah. Lots been done over the last few years. That research that has been done from like Jared Talkington's group about how much incisional hernia happens after colorectal surgery or so on. This is important nuggets of information that are slowly getting in.
Yes, it is. So, right. Well, I think that we pretty much covered everything that we have to cover tonight. Thank you, Tinta. It's been a really useful session, and I've really enjoyed speaking to you. I've learned a lot from this tonight.
Oh, thank you. Thank you. It's a pleasure. It's been a lovely evening.
Yeah, I hope it's been of use to people. I'm sorry that people couldn't join us live through Facebook, but we will share this video on this group, and it will also be available in the European Hernia Society's YouTube channel for everybody to watch as well.
Yeah, I've enjoyed talking and discussing about these things. I always enjoy talking about abdominal wall hernia anyway. So this is another facet that has, and it's really important to, so I've approached this not as a consent lecture, but as how does a patient empower themselves with information that they need.
Yes, okay. So I think if nobody's got any questions, and because we're not on Facebook, possibly they haven't, but I'm sure the questions will come afterwards, and we are available to answer questions. You know, you can get me anytime. So thank you to those who did join us, and thank you, Chinta.
Thank you very much. Okay, bye.
Bye.
Yeah, thank you for inviting me.